night in winters at 9 o'clock. है ना? It's our honor to have you on the board. So please start.
Thank you so much for the kind invitation, sir. So this is one of the very important topic, that is PAP adherence in sleep medicine. I can say that this is the most important topic because all the future aspect of OSC patient depends just upon the PAP adherence. So whenever we prescribe PAP, what happen actually, we prescribe PAP within 5 minutes, but patients have to accept it for the lifetime. So for us, it's just a machine, and for them, it's a fear, frustration, and a fatigue. Just a second, please. Just some issues with my laptop. Just a second, please. Okay, I'm sorry for just a technical issue. So, what are the thoughts of every sleep physician when I started my sleep medicine? So, these are the questions I always have in my mind, that why do half our patients quit CPAP within weeks? And are we just treating numbers or actually helping people sleep better? And do we follow them with empathy or just adjust pressure settings? And if PAP adherence is a journey, who is walking along with the patients? So these are the question I think all the sleep physicians who start their journey are having in their mind, that why do half of our patients quit CPAP within the weeks? Coming to the definition of PAP adherence, using PAP for 4 or more hours per night for at least 70% of the night during a consecutive 30-day period, that is any time during the first 3 months of initial use. And these guidelines dictate that the cost of PAP is covered only for the first 3 months after the initial diagnosis of OSA for their beneficiary. This definition is given by the insurance companies of USA. This definition is not given actually by any official guidelines dealing with the sleep medicine, either American Sleep Academy or Australian Sleep Academy of Sleep Medicine. This is given just for the insurance purpose. So this should be decided by us, the sleep physician, that how much time the machine should be used. So what is the ideal number of how much hours the PAP therapy should be used? So 8 hours of CPAP every night have a beneficial effects on blood glucose in OSA patient with diabetes. And we know hypertension has been associated with REM IHI, and all we know that REM sleep is maximum during the morning hours. And 4 hours usage to define adherence may not be sufficient to provide the to prevent the development of hypertension in patients. So, and normal levels of subjective sleepiness, memory, and daily functioning have been improved if a patient has used machine for 4 hours, 6 hours, and 7.5 hours respectively. So, what is most important that OSA patients should use PAP therapy for entire sleep period on all nights. So, it should not be like that to use PAP therapy for only 4 hours. It should be used for maximum part of the sleep and all nights. And so, how we need to check the PAP adherence, because patients always overestimate their PAP usage, and objective compliance is always low and it ranges from 50 to 80%. So, there is important to objectively monitor the PAP adherence. We need to download the data from PAP adherence, and in older machines, data used to be downloaded manually from the SD cards, but all the newer machines of Philips, ResMed, they transmit these data wirelessly to a cloud database which can be remotely accessed by any healthcare provider. So it also provides the information on the reason that why there is a non-compliance. There may be some residual obstructive events, or there may be some major mask leaks. It also helps to differentiate or define why the patient is not able to use the machine for maximum part of night. So how often one should follow up the patient? Exact frequency again is not mentioned anywhere. These are the Australian guidelines which always state that it should be follow up around 1 month, 3 months, 6 months, and 1 year. Normally, what I use or I follow the method is whenever we prescribe the PAP therapy after the sleep study, we call him or her around after 1 week or 15 days, because this first week or first 2 weeks and even first month is very crucial for the follow up of the patient. And if patient continues to use PAP therapy for around 1 month, there are high chances, and studies have been shown that patient adherence and compliance is much better if patient continue to use PAP therapy for 1 month or more. So follow up can vary from patient to patient, country to country, or doctor to doctor, as clinical literature does not guide us about the exact frequency of the follow ups. So, what are the factors which affect the adherence? These can be simply classified into the patient related, the therapy related, and the clinician related. The patient related factors are the most important one, that is disease and the symptom severity, nasal resistance, education about the therapy of benefits, patient perceiving the benefits, social support. This is the very important aspect of the adherence, partner interaction, comorbidities, and any psychological factors. So the therapy related side effects of CPAP, like pressure ulceration, aerophagia, skin changes, and claustrophobia, and the clinician related barriers. Whenever there is a poor patient relationship, there is a lack of clinician follow up, and there is a create falsely elevated expectations and unwillingness to educate patient. So first and foremost step is always is to educate the patient. So, which factors are there to predict the good PAP adherence? If patient is having excessive daytime sleepiness with Epworth sleepiness score of more than 10, these patients are found to have a good PAP adherence. If there is an increased disease severity, means there are high apnea hypopnea index along with oxygen desaturation index, and patient perceiving the benefits of therapy, that's improvement in symptoms and disease severity within first few months or within weeks, and good adherence and less side effects in the first month of therapy. As we already discussed, that first month is very important to continue the success of the PAP adherence, and the self efficacy, that is patient believe that they can use PAP successfully. So, what how we can improve CPAP adherence? This is the most important thing, I think, as a sleep clinician or physician. We should know that it is always a multidisciplinary aspect. We need to educate and counsel the patient. There should be intensive patient support, behavioral interventions to improve the PAP adherence, causal collaboration, and we need to address and discuss the all machine related issues. So coming to the first and important part, that is education. Education and counseling is the first step toward empowering and encouraging therapy adherence in patients, and it can be achieved through group session. You can call around 2 to 3 patients to discuss the topic together. It can be discussed in outpatient, or also can be discussed in telephonic visits. And we need to share some written literature and presentation, or also we can show some audio visual program to educate the patients. And we also need to discuss the consequences of untreated OSA at length, that is health risk and personal cost involved. So always highlight the purpose, that what are the benefits of the CPAP therapy. So next step is the intensive patient support. That is the assessment of CPAP, compliance report on the mask use hour per night, that how much amount of mask leak is there, and what is the apnea hypopnea index or the residual AHI after the use of CPAP machine. And always every patient should be given a feedback, and there should be a motivation based on the compliance of the report. And repeated addressal of common side effects should be there on the every visit, and there should be remedies for the same, that if a patient is having some issues with the mask or nasal obstruction or there is a leak, we always need to address these issues on every visit. And mask fit should be checked to ensure the patient comfort with the mask. So there are many apps which actually check the mask size. You can download these apps, and they actually give you a rough idea that which mask fit is better for the patient. Either you need to use small, medium, or large size mask according to the face of the patient. Coming to the behavioral intervention, I again say that cognitive behavioral therapy is one of the major aspect of the sleep medicine. You or anyone in your team partner should be involved in the cognitive behavior therapy, because there is a major component of patient with comisa, that is comorbid insomnia along with depression, and we need CBT or motivational enhancement therapy in such patient. And always there is a principle of motivational interviewing, and its aim is to basically elicit the critical thought in the patient regarding his or her ambulance that is towards the treatment. And we need to highlight the patient's own motivating statements around the therapy. And it is all very helpful in managing comisa patients. And always try to get the help of a psychiatrist, or you get self you trained in sleep medicine, where you have the training of the cognitive behavior therapy, because counseling and CBT is one of the major part of the program of the OSA and comorbid depressions. So again, spousal involvement, because whenever we take the history of any patient of OSA, OHS, sleep apnea, we always ask the patient spouse the history of the patients. So there should be always spousal involvement, and it has been documented that it increases the CPAP compliance. And the spouse should encourage the patient to use CPAP nightly, and also help to clean the machine together, so that there is a collaboration, because it shows the most effect when both work together to solve any problem. So, what are the PAP devices settings we need to do to increase the comfort of the patient? So, this is the first feature, that is adding or increasing the heated humidification. In which patients we can use the setting? Those patients which are having component of nasal complaint, like nasal dryness, nasal congestion, morning sore throat, mouth breathers, and those using higher pressure, they may get benefit from adding humidification. And how it helps? It reduces the nasal dryness, nasal congestion, and it improves the comfort and improve the adherence. So how to add or adjust humidification on a PAP machine? First, check the model compatibility, which model you are using. Most of the model machine, that is ResMed, Philips, they come with built-in humidifier, or sometimes you need to add a humidifier. There's always a space with machine to add the humidifier, and you just need to turn on the humidification settings in the device menu, and always start set between 1 to 8, and just start around 3 to 4. And always use distilled water to avoid mineral deposits in the humidifier. And next important thing is the pressure relief technology. It is mostly used in those patients who are having difficult to exhale against high pressures. So it is done to provide the comfort during exhalation, because this technology downs the pressure while exhaling, and it is beneficial in those who are having intolerance to high pressure while exhaling. And different manufacturer have got different name to this technology. You just need to switch on and switch off, and machine will automatically drop the pressure during exhalation. So how to adjust the setting? If you are using a ResMed machine, go to comfort setting, and here it is called expiratory pressure relief, and you just need to on the setting. And level 1, 2, and 3, mostly in our patient we used to set level between 1 and 2, because at expiratory level 3 the pressure drop can be up to 3 centimeter during exhalation. And in those patients who are having high component of AHI, and those who are having some part of OHS, in these patients it can cause pharyngeal collapse, which can lead to residual AHI. And if you are using a Philips model, you just need to go to flex setting, and it will be having a C flex or A flex, and again you need to set the level of 1, 2, or 3, and mostly try to set the level between 1 and 2. And next is the changing mask type. It has been shown that nasal mask and pillow are associated with better PAP adherence, and there are less side effects like uh, because in this mask it has been shown that there are lower pressure which are required to open the airway, and less leak as compared to oronasal mask. And when we need to change the mode of PAP device in those patients who are intolerant to CPAP, in such patient you need to shift to them to BiPAP, and it has been shown to improve adherence in patients who are having intolerance to CPAP, and by shifting just to them to BiPAP, adherence has been improved. So I think mask type is very very important, because when I started my sleep medicine practice, all the patient, if they are admitted in hospital and come with type 2 respiratory failure, and while discharging we just need to write, we always write oronasal mask for all of the patient. But uh, when I studied about this through Dr. JC Suri sir and Dr. Tripdeep, that all the patients need not to be put on the oronasal mask. Around 80 to 90% patients get the benefit through the nasal pillow or nasal mask, and they are very comfortable for the patients. And those patients who are started on nasal pillow or nasal mask, they are having much good adherence always. Because what was the actually concept, that most of the patients, we used to ask, you are a mouth breather, and we just that he's a mouth breather, just start him on oronasal mask. But there's a difference between mouth opener and mouth breather, because whenever patient is having a component of obstructive sleep apnea, and there is increased nasal resistance, patient just need to open the mouth to get the air. But if you are giving nasal pillow, and if his obstruction part is improved with the nasal pillow, then patient will not open the mask. So just basically you just need to get relief his obstruction, which can be done even with the nasal pillow or nasal mask. So, what are the pharmacological intervention? You can use sedatives during the initial exposures, and it is not recommended for every patient. So these patients who are having comorbid insomnia or depression, like the component of COMISA, those patients may get benefit by adding the sedatives. And zolpidem has not been shown to improve any adherence. Aspiclone, it has been shown to improve the PAP adherence, and trazodone, it can also be given in patients who are having low arousal therapy, low arousal thresholds. So you always need to check for the troubleshooting of the PAP side effects. Always ask for the any mask related issue, that is, if there are some leak correction, you need to readjust the mask, check mask sizing, and check for the any damage of the mask which is causing any residual leaks. Always check for the nasal congestion. You can add heated humidification. And if a patient of nasal pillow or nasal mask user, if still opening mouth, first, you can use a chin strap just before shifting him to oronasal mask. You can use chin strap and oronasal mask if still mouth leak persists after using chin strap on nasal pillow or nasal mask. And also, if a patient is having claustrophobia, nasal pillow are the best mask. You can go for mask desensitization, where you just need to make him sit in the OPD and give him a trial of CPAP or BiPAP by holding the mask with your hands, and telling to patient that you just need to inhale and exhale. Just tell him to be calm and relax. And it has been shown that mask desensitization has been uh, known to improve adherence in patients those having component of claustrophobia and also aerophagia. And it is also always more common with oronasal mask. We always see patients of COPD who are put on BiPAP in respiratory ICUs. They are having component of aerophagia after the use. And in such patient, you can just elevate the head end of the patient, and you always can lower the fixed CPAP pressure or a trial of auto CPAP in such cases. And those patients who are having difficult to exhale against pressure, such patients may benefit from pressure relief technology. We already discussed in Philips and ResMed machine, different name is given to different setting. It can be EPR or Reflex or C-Flex. You just need to on the setting and press 1, 2, 3 level, try to get between 1 and 2, and patient is complaining of too little pressure, you just need to increase auto minimum pressure to check the auto CPAP, and always check pressure delivery by the CPAP. And if still after doing everything patient is having persistent snoring, you can increase fixed CPAP pressure, or you can increase auto minimum on CPAP. And always advise the patient for the weight loss and increase auto maximum pressure. So we will discuss few case scenarios. There's a 32-year-old woman with moderate sleep apnea, complaining of that her mask is making very loud noises and is disturbing her bed partner. She's a side sleeper and also reports that she wakes with extremely dry mouth. So what to need in this case? Patient is having a persistent leak. You can add a chin strap or you can use a nasal pillow. Okay, very simple case. Also, second case, if a patient, 52-year-old male with severe sleep apnea, and he's recently just initiated on CPAP therapy, and he discontinued quickly due to nasal congestion. We know nasal congestion, one factor is like dryness. We can give a trial of heated humidification, and also we can give nasal steroid. These have been shown to improve adherence in patients who are complaining of nasal congestion and nasal dryness. Other case scenario, a patient of a severe sleep apnea using a pressure of CPAP 10, and patient is complaining of inability to exhale against the pressure. So in such patients, we already discussed that you just need to set the pressure relief. Other patients who are having severe sleep apnea who is using CPAP at a pressure of around 17 and also pressure relief at set at 2, still he stopped using CPAP due to abdominal pain, extreme belching and pressure intolerance. We know this is areophagia. We just need to elevate the head, and always we can shift these patient with BiPAP, and we can do a titration study in the laboratory if a patient is not willing, because already patient has spent and done a level 1 polysomnography. You just can give him a auto BiPAP trial. So if a patient is 33-year-old female with a history of anxiety and depression, and also there is a history of remote history of abuse, as child was diagnosed with severe apnea, and when she tries to use her CPAP, she has a sense of panic and cannot proceed. So what to do in such cases? Here you can take the help of a psychiatrist. They can be very helpful, and you just need to call or send the patient for the counseling session, and also you can go for desensitization protocols and PAP nap therapy. So the always best way to improve PAP adherence is just through the machines, mask or settings. It is by working together as doctor, because sleep apnea is shared by all, either dental, ENT, neurologist, with the pulmonologist, all the therapists, families and patients. We should always work together to improve adherence in patients. And teamwork is not an option, it is the treatment. And let's continue to heal sleep together. So after all, we know that just look at this couple who is sleeping very peacefully. The mask is on and snoring is gone, and they are finally sleeping like babies. Now, whether this piece is because of CPAP or because they are too tired to argue, because science still can't confirm. Because let's be honest, CPAP success is rare, and husband and wife sleeping peacefully even after doing everything, it is even rarer. So thank you so much for the patience.
Thank
Please.
you very much. Thank you very much, Dr. Dilbag. It is a wonderful lecture, and
Thank you
I
so
think most of my questions has been covered. Any
much.
questions from the audience and the faculty who has joined? Please ask if somebody has some questions. Okay, I have some still doubts in my mind.
Yeah.
That first of all, you are using auto CPAP or manual CPAP?
Okay, sir, if we are mostly what we are doing, I will tell you my technique. We get a level 2 polysomnography, or if patient is willing, level 1 polysomnography, and we only do diagnostic studies. Sir, we mostly we always avoid titration study, because what is the reason behind that? most of the patients complain that after the first half, technician is not telling anything and they're just putting a mask which patient is not knowing anything about. So what we always try to follow, we just do diagnostic study, then we discuss the patient report with the patient that this is your report, you are having this part of AHI, you are having this much desaturation, and now we need to treat this problem, and to treat this we need your cooperation. And for this we have a little machine for you, you just need to put on this machine, and we give them a trial of auto CPAP, sir.
Okay,
And
okay. I mean, that's a good thing that I have seen also that if you are doing both
yes,
diagnostic and as well as titration, around 30 to 40% of patient are claustrophobic, and
yes, sir.
sometimes technician just put the mask and sleep.
Yes. Yeah, yes,
He
yes, sir.
sleeps first than the patient,
Yes, sir.
and patient next day complaining to us that your technician sleep after putting that mask, but I could not able to sleep. So
Yes.
how you find out that this pressure is correct?
And also, sir, most of the patient lost to follow up in such cases, and they're not
In India, sleep studies in infancy today also, it
till
is the tip of an iceberg because 90% of the doctors do not know how to treat, how to
yes,
manage, and they also argue with other doctors. Why you are treating? Is it required? Even
sir,
in the ICU, if a severe OSA patient admitted, they are
yes.
arguing, is this required? Is this is a such a element that it is causing this?
Yes, I truly agree with you, sir. Because in Punjab also there is a much lag part on sleep medicine, because most of the patients think that snoring is a sign of healthy sleep. मोस्ट ऑफ द से दैट खराटे आ रहे हैं तो बहुत अच्छी नींद सोए हैं, घोड़े बेच के सोए हैं, लेकिन या वी नीड टू स्टिल गेट अवेयरनेस.
And I have seen that both auto CPAP and manual CPAP are good if
Yes,
you are doing diagnostic and titration on other days and you are explaining the patient correctly. You are
yes,
counseling the patient correctly.
yes, sir.
And I have seen lots of patient are started on oronasal mask
Yeah.
titration
Sir,
despite not having such a high pressure.
yes,
Yeah,
sir.
and they said that he is snorer by his mouth snoring, mouth opening is there. He
Yeah,
is snoring by last 10 years with the mouth opening, mouth is, open, and even they started by self.
yes,
Some companies are promoting to them that you start BiPAP auto, CPAP, and the pressure generated is the final.
yes, sir.
You do not have to go for sleep study.
Yes, sir. I truly agree with you, sir.
And this
Because
is very common. Even in Delhi, it is very, very common. Patient call me that, sir, you are a sleep specialist. What is the rate? What is the rate? And how you proceed?
sir,
Uh,
same happening in Amritsar also, that like we used to charge around 8 to 10,000 for level 2 sleep study, and if we are doing it in hospital also, we charge it around 10,000. But most of the like companies or these technicians, they are doing the level 3, level 4 sleep studies, and they are doing it for around 3 4,000, and then patient is calling you that same sleep studies is get done by then around just 3 and 4,000. Why you are charging so much? Then we just need to explain them the whole story, that this is the report, you just can compare both of the reports. Just ask your sleep technician what he or she knows about the sleep medicine, because this is like other medicine, and like other specialty where you just need to know everything about the patient's brain, physiology, pathology, and the patterns of sleep. And what I used to say my patient, that the name of test is sleep study, na? Sleep study. And in level 3 and level 4, we are not even recording your sleep.
okay, what is your experience with nasal pillow versus CPAP
So nasal pillow
versus CPAP?
versus CPAP.
Because nasal pillow, I do not found in many cases good enough to reduce the AHI.
Okay. So those patients who are having less pressure requirement, they are actually getting benefit with nasal pillow also, sir. But in those patients who are having high pressure demand, in such patients, we sometimes need to shift them to nasal mask, sir.
I
And
have seen many patients with who are mouth breathing with AHI more than 30, 35, 50, and they are on nasal pillow prescribed by some doctor.
Okay, in such patients, sir, if residual AHI is very high, and we need to just also see the compliance report, and if leak is there, so we need to shift this patient to BiPAP ST and also with like oronasal masks, or also we can
Okay.
get titration study with BiPAP ST.
Yes, yes, yes. Very true. Thank you very much, Dr. Dilbag,
Thank you
once
so much.
again.
Thank you for this kind invitation and opportunity, sir.
Okay, so we are closing the session. Thank you very much,
Thank you.
everyone, for
Thank
joining.
thank you so much, sir.
Dr. Rajan?